Professor Indra Agarwal is HOD in pediatric nephrology in CMC Vellore, and she will be conducting the whole session. The pattern of this session will be that we will be starting with a short lecture on pharmacology and pharmacodynamics of MMF, keeping in mind its uses in pediatrics, if as well as maybe we might have some from adult, and then Dr. Aditi will sort of explore on what is it in pediatric usage. What are the evidence in it, and I'm sure we will have a lot of questions for both of them. I would like to thank Intro Brands for sponsoring this, and without wasting much time, I would request Adita, if you can unshare yourself, if you can go out, and then Dr. Ratna Prabha can upload her slides. And it is over to Professor Indra Agarwal.
So I'll start while they are setting up the slides. So first of all, thank you to Rajiv and the team at the ICH for this excellent initiative that they have started. And I think it will be excellent scientific sessions that have been planned by them. I would like to thank you all for inviting me to also moderate this session. So just with a brief introduction about MMF, we shall proceed. So MMF has been around for quite a few decades now. It's been there almost more than 2 decades. And it actually reminds me of my time during my training in Adelaide in around 2000, when there was a lot of excitement about this new drug which had come with an indication for nephrotic syndrome, which was previously known to be used in cancer in transplant patients. And so this is somewhere around 2000 when a publication came out in, I think, JASN about its use in dependent nephrotic syndrome. And frequently relapsing nephrotic syndrome. Since then, we've come a long way. There have been lots of studies that have come up regarding this, and many of them, the Indian studies, have been spearheaded by AIMS, and it has now become quite a standard of care. Also, the indications for MMF have also widened, and we're using it in many more types of glomerular disease. Now, our first talk will be regarding therapeutic drug monitoring and the role in the management in nephrotic syndrome or glomerular disease for that matter. So actually in CMC, the clinical pharmacology unit is probably it can proudly say that they're one of the first few centers to start this MPA monitoring way back in 2000, around 2000, 2001, when at the request of our senior nephrologist, Dr. George T. John, it was initiated, and the then head of department, Dr. Denny Fleming, actually set up the assay. It was initially done in transplant patients, and over time, gradually, it has been introduced in other situations also. And in children, we have been using it for the last 5 to 7 years. Not many centers are doing MPA monitoring, so not too much information is actually available from other centers, including the US. So Dr. Ratna has been involved. She's a professor of in clinical pharmacology, and she's been involved in MPA, TDM, the therapeutic drug monitoring in several studies, and has a lot of experience in this area. So we're quite happy to invite her to give the following talk on the usefulness of therapeutic drug monitoring of MMF in nephrotic syndrome. So over to you, Ratna.
Thank you so much, Dr. Indra Agarwal. Just give me a minute just to share my screen, and then, yeah. So thank you so much, and good evening to everybody for inviting me and sharing my experience in therapeutic drug monitoring in adults as renal transplant patients especially, and followed by from last, as Dr. Indra said, from last few years, 4-5 years, we are doing monitoring in children also with various diseases like SLE, steroid-dependent nephrotic syndrome, steroid-resistant nephrotic syndrome. There are various conditions what Dr. Indra Agarwal is suggesting, and we are doing this therapeutic drug monitoring of MPA. in children also. So I would like to start from that, like what is the outline of my presentation is that because as you all know, I'm the pharmacology department, and I turned up to clinical pharmacology department where Dr. Danny Fleming said that therapeutic drug monitoring of MPA, and followed by now we are doing so many drugs like tacrolimus, everolimus, sirolimus, and many antibiotics. And recently we have started doing that azathioprine, what is, we do the TPMT enzyme activity followed by metabolite. What is the next drug after MPA that people wants to uh, uh, take care of? Because, okay, so that is the thing. And what is the importance of doing therapeutic drug monitoring? And as we all know, the various brands of MPA and their prices comparison, I would like to, in very brief, I would like to tell normal profile of MPA, what is that, and our experience in adults as well as in children, and what is the take-home message that I would like to present in my own presentation. So, as is normal pharmacokinetic of MPA, if you see that, here you can see that this, once we take the oral MMF, it goes to GIT and it converts to MPA by hydrolysis, stage hydrolysis, followed by it goes absorption. Just hold on for the moment for the recycle, and that goes to central nervous system. It distributes all over the body. In the periphery, especially in the liver, it converts by UGT enzyme to MPA and to MPAG. What is the glucuronide metabolite? What is non-active, which is non-active metabolite of MPA. Then it will go to, it will eliminate, basically it will, MPAG will eliminate through urine, or you can say from kidney. Part of the MPAG, it goes to the bile, and from there it goes to GIT, where GI bacteria deglutatize this MPAG again, and GIT again MPA will absorb. That's how the enterohepatic cycling happens. But if you see here that two things are there. One is recycle, that is the enterohepatic cycling by GI bacteria, followed by, if you see this down as MRP2 is another enzyme which is responsible for that elimination of MPAG into bile. So there various things are there what can make the difference for that MPA absorption as well as reabsorption in GIT. So, if coming back to pharmacology of main, we all know that this MPA is almost 97 to 99% is a bound form with the albumin. Only and free MPA is only 1 to 3% is active, which is a free, and it's, we say as per literature we say active form. As I said that MPA converts to MPAG, which is a glucuronide form of MPA, that is 82% plasma protein form. Interesting thing here is that MPAG and MPA, they both bind to the albumin in reversible and competitive manner. If MPAG concentration goes higher, for some reason that I'll tell you later, it will displace MPA from the albumin binding site. And free MPA will come to the circulation. It will get again converted to MPAG and will get eliminated through the urine. So that is the. So what matters for the total MPA concentration? So matter here is a plasma protein. If plasma protein is lesser, pre-MPA will be more in circulation. It will get eliminated faster. Kidney function, because MPAG gets eliminated by MPAG. If kidney functions are not working properly, serum creatinine is high, renal function not good, then MPAG will convert to, will not eliminate from the body. And again it will displace MPA from albumin. Food is another factor, but many clinician, or it's a stigma like that, we take medicine after food. But what we have seen here, we have done one study also, when we take MPA or MMF before food, that absorption is much better, Cmax comes faster, and AUC is also better. Why the liver function is coming? If the liver functions are not working properly, or is not, LFT is not good for longer time, liver will not be able to produce the albumin, and that's how hypoalbuminemia will happen, and then again that it will affect your total MPA. So these are the factors what affects the total MPA concentration. Okay, coming back to that, what we all know that is MPS, a mycophilic acid, what is the active compound. Roche was the first company which produced that, which synthesized, and it was innovator that came in the market in the cell set. And there, but though cell set is very good, it was good and it still is good. It has a reputation. But problem was that cell set, it is quite expensive drug. I still remember that few years before, one of my near and dear, they were prescribed 1 gram BD. 1 and 500 mg comes with a 110 rupees. So it was a bit difficult, 400 rupees to spend Cellcept only on the Cellcept. Forget about other medicine, the Cellcept was quite expensive. So in that way that another drugs, generic drugs came, it was cheaper and it was quite cost effective. And not more than that, Cellcept was used to cause GI side effect also. GI side effect, one most common side effect were nausea and vomiting and GI irritation. When these innovator drugs or generic drugs came in the market, the prices also came down and side effects also came down and it's quite popular. So this entry coated drugs, I have the few preparation that what I can show you here, Rainfur, Immutulas, Myfortic, Mycof. But in my CMC pharmacy, almost 17, 18 brands are there what are available in this. So it's not only that. So that is the story of Cellcept coming back to Mycofit, Mycomil, and like that. So if you see the price wise difference was like a Cellcept was the now this is you can see the Cellcept 65 rupees. I'm showing 500 mg because this is subsidized rate by that company because CMC has negotiated these prices. So that's why they are giving 65 rupees per 500 mg. But time was there when Cellcept was quite expensive. Coming down to that, you see the down Myfortic, Rainfur, these are the entry coated preparation which causes less side effect, nausea, vomiting, and other side effects also what Cellcept was to cause. So that is but these are quite expensive. If you see that's how the Cellcept 500 mg or MMF 500 mg is equal to 360 mg of Rainfur. That study also we have done is Cellcept 500 mg is equal to 360 mg with lesser side effect. These are the certain uh, so when we are doing that ultimately we'll land up with the therapeutic drug monitoring. So if patient can afford with the uh, uh, you can say the MMF 500 mg, why to expend 86 rupees for this preparation, 500 rupees. So that is the thing. So why to do MP therapeutic drug monitoring, that's a question. Because as we all know that is a There is a clear relationship between drug concentration effect. Many studies in transplant and non-transplant patients has been done and they found that there clear-cut correlation between drug concentration and clinical outcome. And what is the for basically renal transplant patient, what is that has been decided or the literature says if that MPA AUC 0 to 12 hour or area under concentration curve is 30 to 60 milligram per hour per liter, rejection rate is much lower in comparison to if patient has less than 30. Second is why another thing is considerable interpatient pharmacokinetic variability. Means if one patient is taking 500 mg per 500 mg BD and he is achieving therapeutic range. But another hand, one patient has to take 1000 mg BD to achieve a 36 milligram per hour per liter AUC. So it's a considerable interpatient pharmacokinetic bioavailability and many other factors are there. So we need to do the monitoring. The pharmacological response of the drug difficult to assess. We cannot say like insulin. If you take that this much insulin, your blood sugar level will go down. Or one side you say that antihypertensive, you cannot monitor that like that. So you have to see how you have to do bigger study to say if you have achieved this or patient has achieved 30 to this therapeutic range, rejection is much lower. And this other thing is that lesser side effect in compared to other immunosuppressants. Like we have a lot of experience in adult transplant patient. Now we have a non-transplant adult patient also. Why I'm saying because if some patient cannot are not on 500 mg BD, they are on a much higher dose of tacrolimus. Tacrolimus is a very short therapeutic range. If a patient does not monitor or didn't monitor cleans and didn't ask for the monitoring, patient will land up, blood sugar level will be very high, patient will have tremors, and there are various more side effects with this immunosuppressant. Same way for the cyclosporin, same way for the prednisolone. So MP has very lesser side effect in comparison to other immunosuppressant like tacrolimus, cyclosporin, or prednisolone. So if you give that MPA along with other immunosuppressant, you can reduce the dose of other immunosuppressant, and because MPA is very less side effect, you can achieve that goal what clinical output better. So that's why we need to do monitoring. But question is that why many centers are not doing that? Because MPA is that, like I remember when I joined this clinical pharmacology department, we were doing this tacrolimus by immunoassay method, because that was the kit. It was very easily that it was very easy for all of us to do tacrolimus by kit method. But unfortunately, or whatever you say, there is no approved method by which we can do monitoring of MPA by automated simple assay. That is the one reason. So the center which, though they want to do that monitoring, but they don't have HPLC or LCMS, because it's quite expensive thing. So that is the one reason. Second thing is, many clinicians they say, oh, already this is a low rejection rate with empirical dose of MMF, so why to do monitoring? But problem is not that. Empirical dose we don't know. We say so how much for one clinician 500 mg BD is enough. For another clinician they will say no, 1 gram mg is 1 gram BD is enough. So it's a quite different dosing pattern between the clinician to clinician. So and MMF doesn't cause much side effect. That is another reason. Second thing is, it's a complex, coming back to oncology level, we say it's a complex pharmacokinetic of MPA is very difficult to monitor. That is another reason. And no major organ toxicity, as I said, by the MPA. So I'll show you, these are the certain brands I can show you that how they behave, they show the absorption pattern. If you see, then they all have the different pattern. Myphotic, you see here, this is a first picture is showing myphotic pattern of absorption. Another one is cell set, or you can say MMF. This here you can say very, third picture is very good. Enterohepatic cycling is there. Fourth, Rainford. Many times Rainford peak because of the anticotic tablet. Peak comes very late, 2.5 or 3 hours. But because this is a enterohepatic cycling, it's a late absorption happened. In the morning dose, you can see trough. Here is a very high peak, you can say here. It's a very high trough is there. Cell sept is very consistent. So far in that many years I have seen the very consistent pharmacokinetic is there. Absorption pattern is the fifth picture. If you see, that is absorption pattern is like that. And myphotic is another, what you can say, it comes around 2.5 or 3 hours. So that's how that, so that's the thing, it's a MPA, different preparation shows different pharmacokinetic, so is a person, a clinician or clinical pharmacologist are not very under concentration. So they are not So this is a simple picture of HPLC UV detector. In our hospital, we have LCMS also. Normal showed in previous slides that normal plasma drug concentration profile after oral administration of MMF. I haven't taken any picture of that or any profile of entry coated preparation because they show different pharmacokinetic. But this MMF very consistent. So that's why I'm showing you this picture. That is the absorption happened within 0.5 hour or maximum 1 hour. C max comes, and so But Cmax comes around 1 hour or zero point 0.5 within 2 hours that Cmax comes, and we can just say that's it. So if you see here from 12 to up to 12 hour, we have done many studies in this our department. I'll show you if you study what we have done and published also. So this is, you see here that up to 6 hour you can see peak came 0.5 hour, and after 6 hour there's a very flat line is there. You see from here 6 hour up to 12 hour. That is our patient what I am showing you. This is up to 6 to 12 hour, very flat line is there. So how to calculate that AUC in these type of patient? So Cmax and Tmax, and that is a C0 trough. We all know that before taking the next dose, that is a C0 or trough. So how do you do here? This is the, as I said, this is a, so we do, it's a very standard mathematical equation. What we do is a Trapezoid method for calculation of AUC. So this is how do you do 0 AUC 0 to 12 hour. As it says up before 6 hour, you can calculate by trapezoid method AUC 0 to 6 hour. But if you see after that 6 hour, there is very flat line. So what we did, we thought C0 into 3 and divide into two parts, C0 into 3 and C6 into 3. So whatever concentration at 6 hour, we'll say that is goes for the later half of that absorption, and C0 and 3 in the first part of the absorption. So that's how we calculate AUC 0 to 12 hour in our patients. So we published one study in the 2006 that because still we were not sure till we do it. So we did one study in 39 patients and published also. We saw that when we do 6 hour AUC by doing this method 3 into C0 and 3 into C6, it will be the as equal, and with the 95% agreement, or you can say 96 or 97% agreement, R square was more than 0.95. So there is no difference. Why I'm saying the cyclosporin and MPA? Because cyclosporin inhibit that MDA absorption from bile to intestine, and it was tend to reduce that MPA level. But when we saw the 12 hour and 6 hour patient, it was there was no difference, and that's how we have to do that. So that's how we can reduce from 12 hour to 6 hour. We don't have to do sampling up to the 12 hour. We can save our time, and we can save that blood sample. We can save our inside the lab time also, and lab result turnaround time also will come down from 12 hours to 6 hours. So that is, as I said, I don't want to take any non-sodium preparation because these preparations shows different type of PK. So this is our interim analysis of department. We saw that non-sodium preparation for MPA in 1,219 patients from last 5 years is a mixed transplant and non-transplant, and mean was 42 because these are all are monitored patients, so they achieved their AUC 42.3. Standard deviation was 17, and AUC coefficient of variation, which is for that interpatient variability, it was 42. To achieve that 42.3 level, dose was also that it's a BD, so 1,382 per day dosing was there. But if to achieve that 42.3, we had a coefficient of variation is at 39. So that is a lot of high interpatient variability is there. So we need to monitor these patients to achieve therapeutic range. That is, we made the transplant and non-transplant all the patients. But when we saw in these patients, okay, what is the correlation between dose and AUC 0 to 12? We didn't find, or it was very minimal correlation between dose and AUC. It is only 0.17. So we cannot say we give 1000 mg, we can achieve that AUC. No, we cannot achieve. We have to do that monitoring, and because dose and AUC, there is no correlation, is there, or very less, or it's not significant correlation. So many times what happens is new registrars or new clinician, they come, and some samples we get from the outside also, like Coimbatore or Chennai. They ask, can we do the trough? Only the trough. But as if you see the literature also says that we have to do AUC 0 to 12 hours. Whichever way you do by 6 hours or you do by 12 hours, it doesn't matter. But trough is not clinically relevant for the better clinical outcome. So we thought, okay, we will do also that what is the correlation between the AUC and TRUF. We didn't find any good correlations, only 0.47 or you can 0.48. It's not very good correlation. So we always said, no, TRUF for this, especially MPA, tacrolimus, sirolimus, and other drugs, everolimus, we do the TRUF. But for that MPA, TRUF is not clinically relevant. So we have to do only 12-hour AUC, not TRUF. So there is no correlation. And that time also we mixed population in the adults and children and with a mixed diagnosis. Could we reduce the time further? Yeah, I think we can do it. It's by limited sample strategy. From still, I just want to reduce my sample size from 6 hours to, because in 6 hours also we are doing 10 time point, 10 blood sample. Now still I want to reduce my blood sample. We don't want this much 10 hours, 6 hours sitting and with a 10 blood sample. So that's a limited sample study. So this is another paper what we published in 2010. That was also published first time in our center. This is a reliable limited sample analysis for the estimation of MPA under the AUC in adult renal transplant patient in stable post-term. Stable means after 3 months. So this is a very standard, probably we all of us know, this is a Bald-Hartmann plot where we can say all the AUC, measured AUC with a 5 and 5-point LSS AUC was very good correlation. So, and we did only 5 time point to predict very good correlation. So still we can do it. So question is that one dose and one equation fits to all, especially in children? I don't think so. Because children, when they come to us with the various diagnoses like nephrotic syndrome, SLE, rheumatoid arthritis, there are various diseases are there. I'm not very much sure how many you people see, but it's not fit. Because children are very much different from adults. First thing, their body surface area is much higher than adults. Second thing is that their metabolism also is very fast. Third thing is that if children are coming with some renal disease, so probably their renal functions are not working properly. Their renal functions are not good. Serum albumin is not good. Proteinuria is there. If proteinuria is there, MPA will get eliminated or MPAG will not get eliminated from the renally. And these are the many factors are there what we have to consider. So one dose and one equation fits to all. It will not fit for the children especially. So blood collection in children is often challenging. Thanks to Dr. Indira Agarwal, she has given me so many times opportunity to do this thing. Can be reduced further because very difficult for it's not fair enough for the children to do collect that many time point blood collection. They all are scared. So discomfort to the child and family, not only child, but the family also. Multiple blood collection points, time consuming over 12 hours are traumatic, is impractical, expensive, increase the laboratory turnaround time. So all these points are not good enough for the children. Still, we want to reduce the time. So we have done when we study in SLE patient, and we published this also. That is we did with the 26 patient, and we found it's very good correlation with the 4 time point. I can predict very good correlation with the in the SLE patients. So these are the, and again I say there's a Bald-Hartmann plot. It was very good correlation. Total measured MPA and 4-point LSS MPA UC 0 to 12 hour. These are the things what we do here. So this is another study what we did here is the relevance of measuring MPA exposure by AUC 0 in children with treatment for the nephrotic syndrome. Previous study was with SLE. So this one study is under review for the publication. One of our staff 2 years before she had just passed out from she passed from our she has gone from our CMC. She cleared her exam and she is working somewhere. So we did with her in this study with the 36 children and it's still under review. If it's that you see this one also another is the, in the children also they need because their pharmacokinetic is very different from you see their metabolic rate is also very fast. So most of the children they need much higher dose 1.5 times higher dose than adults. And these children coefficient of variation also 51.76 is that you can see here is very high. So they need higher dose and you see is also interpatient variability is there. So we need to monitor these children also. So they need again monitoring. this under review for publication. I hope it will very soon it will come in the case. So in these children, we saw that what is the correlation between MP, AUC and trough. MP, AUC and trough is very bad correlation, 0.04. It's not good correlation. So I cannot say कि just measure the trough and AUC 0.06 R square. So it's not very good, 0.06. It's not very good. So I cannot say कि no, children, you do the trough and just uh, uh, start the dose, whatever dose clinician needs. You have to monitor AUC. Then we found that is what is the correlation between dose and AUC. There is no correlation between dose and AUC. It's R square, what we say in our terminology is a pharmacokinetic terminology, R square is only 0.06. It's not good correlation between dose and AUC. So this is another source we need to do monitoring in children as well as in adults also. So this is the last slide for me, and I would like to say this is another study we are doing in children with nephrotic syndrome. What is this study says? Exposure of MMF total AUC and free MP AUC in children with nephrotic syndrome. If you see here that the left side table is the remission all the patient in previous study also SDNS patient, remission patient children they achieved good AUC. In nephrotic syndrome again you can, because it's an ongoing study, you see here all the AUC children who were on remission they achieved good AUC and their serum albumin was also very good. Few patients are that like 3 patients among that 11 patients, though their albumin was okay, but they didn't achieve, but it can be various reasons. It can be that proteinuria was there and that a long-term disease was there. We don't know about that. We need to explore this thing. And if you see the relapse side, all the patients who were on relapse, they didn't achieve good concentration of tedium. So still scope is there to increase that AUC, increase the dose. And because there's no much side effects are there, we can say that we can increase the dose in the children who are in relapse and can be better clinical outcome. And mean AUC, if you see among those very limited sample size, mean AUC is 40.1 in remission, but in relapse only 21.99, you can say 22, so quite significant different 0.01. So this is the my thing. So I will insist to do that. What is the take home message? Same dose cannot fit to all patients. Adult and children are different. MMF has high inter-individual variability in terms of kinetic. And what is therapeutic range has been decided in the transplant patient and non-transplant is 30 to 60 milligram per hour per liter. We need to do tedium of MMF to achieve maximum clinical efficacy. In non-transplant children, therapeutic range has to be decided still because we everywhere you can say small studies are there, not big studies, so we have to do that one. And it needs bigger study in Indian population, especially because we are working here. Thank you so much for giving me this opportunity to that. Thanks a lot. I'll be happy to take any question if you want, if anybody wants.
Thank you, Ratna, for that very enlightening talk and lots of useful information on therapeutic drug monitoring. And I think it's quite useful for clinicians to understand many of these things. Now, I think there have been a lot of questions. I think, Rajiv, what would you like to say? You want to, since they're specific to this topic, what would you?
Yeah, we can take one or two questions, and then while Dr. Aditi is uploading, so if Dr. Ratna can, what you call, unshare, and while Aditi is uploading, maybe we can take a couple of questions.
Sorry, I took extra time for that.
No,
but,
no,
it was,
no worry. It was all our learning.
So, Rajiv, you said you were keeping track of the notes.
Yeah. So there were one question. In fact, I also had the same question. Was that if low albumin makes MMF less effective, no, because of this less bioavailability, then like, do we have to use a higher dose of MMF when we are dealing with steroid resist, when we are using it in say steroid resistant nephrotic syndrome, where you have a persistent hypoalbuminemia. And other question, slightly related, was that with all this evidence, but do we really have any evidence which has shown that comparing two groups, one group where we are monitoring the MPA level with area under the curve, and the other group where we are giving the 1200 milligram per square meter, but we are not monitoring the area under curve, and any sort of efficacy or any difference in the efficacy or side effect, any adult or pediatric studies?
Yeah, I would like to say here that the second question first. Any studies showing superiority of MPA with AUC versus MPA? That is in our what I saw. This is our study also. We are showing here. We are previously we were not doing empirically. We are doing, but now after doing that MPA, you see the dose has come down so much. So ideally, we should do that monitoring.
Yeah, but the question is that have we shown any clinical advantage, like either in sort of in terms of efficacy or in terms of side effects?
Maybe I know if I can answer that, and I don't know if it's a very exactly what you're asking, but since much of our treatment is guided by the levels we get, so there have been some children say with very low levels, they're not able to bring up the MPA levels, so we've changed it to the enteric coated drug, and when we repeat the MPA level, we find a much better response, and we find the child also going into remission. So it, I mean, the applicability has been there in some patients, maybe not in all. It has helped to guide. Is that what you are asking, or is it something slightly different?
Yeah, no. I'm like what I'm asking is the same thing, but like, do we have any published evidence or any published studies either in adult or pediatric where they have say compared two group, one group where they have not monitored the MPA level and the other group where they monitored the MPA level, but both group given the optimum like maximum dose permissible, and then said that yes, monitoring is better because it has got better clinical efficacy or it has got lower side effect. Like,
But
have we come out with that evidence, or we are still in the process of generating that evidence?
see, there isn't, as she said, no, there's a dose variability. Somebody may respond at that dose, somebody else may not respond at that dose. Inter-individual variability is there. So both patients getting 1200, one may per meter squared, one monitored, one not monitored, but may have a different response.
So
So
we don't
know.
still
So
have.
finally, we treat by our clinical response, what we see.
And what about the first question, like in steroid resistant nephrotic syndrome, which is like persistent hypoalbuminemic? So will a higher dose work, like or because as Dr. Ratna was saying that if you are having a low albumin, then maybe your drug may not work. Am I right to understand that?
Yeah. So I was telling her the same thing. Probably we've all had thought of the same thing. That actually in the same patient, maybe during, we should be able, if you give a higher dose of MMF and then see whether that makes a change in the level, or in the same patient, we should be able to say that he was in relapse, and so at the same dose, the MPA level was low when he was in relapse. For the same patient, when he recovered, did the MPA level go up? So that's the other way of also looking at it. And that's something that probably still needs to be done.
And we'll have, with Aditi's permission, we'll have two more questions. Dr. Susmita Banerjee is asking that which is the active component? Like, is it the bound portion or is it the free portion?
Dr. Raju, actually, it's a free portion is a active compound, but it's only as in my slide I showed only 1 to 3% is free. So it's extremely difficult to monitor free MPA. You need to have that LCMS, which is very sensitive to monitor. But actually speaking, free MPA is a more active. Free MPA is only active compound.
So supposing you have less albumin, your free MPA should go up.
No, it will not go up, because if it's suppose it's acute hypoalbuminemia happen, then free MPA possibility will be higher if you monitor that moment. But once that free MPA comes out, because your liver is working properly, so immediately by UGT enzyme, it will convert to MPAG, and MPAG will be eliminated from the body. So free MPA will be in the dynamic position. It doesn't go up and down very fast.
Then the response should be the same actually, whether you
It's
have a
not,
low albumin or not.
yes. Then we have to see that what is the proteinuria there, because we have to decide by proteinuria how much protein is going in the, because you cannot monitor that. You have to see proteinuria in, I believe so. Okay,
But
more
I
than,
think our study showed that there was no correlation with proteinuria also.
yeah,
So
that I have to see that, but because we haven't monitored so far that proteinuria in these patients, so we'll see that. But
Okay, so uh, I think Dr. Indra, if we can go ahead
yeah,
with
we'll go
with
ahead.
Aditi's and then
Yeah,
take all the other
so that's
questions.
fine. Yeah,
Session.
there's still many
Maybe
unanswered
maybe
questions.
Aditi will also be able to ask or some questions or
Yeah,
answer some
sure,
of them.
sure, sure. So anyway, we'll move on because we're running late as well. So I think Aditi doesn't really need any introduction. One of the most dynamic associate professors from AIMS, who's a very keen researcher and has been involved in a lot of studies on nephrotic syndrome, starting with Dr. Baga as early as 2003 when the drug first came into use in nephrotic syndrome. So I'm sure she'll take us through this journey and tell us something more about the lessons we've learned along the way. Over to Aditi.
Uh, Hi, good afternoon. Thank you, ma'am. Thank you, Rajiv. And thank you, Dr. Ratna, for such an excellent beginning lecture on the pharmacokinetics. I'm grateful to Rajiv for giving me the opportunity to talk to you again. Incidentally, it's just exactly 1 year post my last visit to Kolkata for another talk on nephrotic syndrome today. And at that time, on the way we had the kind of seeing newspaper clippings, one side corner mentioning some virus circulating in China. Little did we know where we would be 1 year later. Anyway, with that digression, may I just begin with MMF and nephrotic syndrome? And the outline of my talk is such, and may I just ask whether we still have time to do the entire 30 minutes, or do you want me to abbreviate the talk?
No, no, please 30 minutes.
Okay, thank you. So these are the small. This is just a short list of what I would be discussing, and obviously we will be focusing on the evidence of efficacy in nephrotic syndrome for especially for steroid sensitive nephrotic syndrome where it has most been studied, and some things about safety and therapeutic drug monitoring as it has been done in nephrotic syndrome. So essentially, we have preparations available as tablets, capsules, syrup, and MMFS preparations, that is the enteric coated and the sodium preparations and that we were talking about. And while most companies, I've listed just a few of them that are more commonly available, but obviously there are many brands available, including the sponsors. And the tablets are chiefly available very readily at 500 mg. Majority of these are not meant to be broken or crushed or cut prior to ingestion, unlike what very often we tend to be practicing in our practice in some centers at least. And then there are capsules of 250 milligram, which are essentially capsules, but most brands that used to make have now discontinued making the 250 milligram capsules because it's not probably profitable to them to continue to make this product, which is chiefly targeting children, given the small market that children constitute. Uh, the good thing is that syrup preparations have now begun to be more readily available. Previously, just Cellcept was available from Roche, but now we also have Mycept and Moficon OS, and we look forward to more preparations becoming available, which makes dose titration much easier for children and seems to be working fairly well for children who are on these preparations. So as we've already discussed in the prior topic, it is better that the medication be taken on an empty stomach because fat diet and other things could reduce its absorption or interfere with its absorption. Uh, with that, I'll just briefly talk to you about the mechanism of action of mycophenolate mofetil. So this has also probably been touched upon. It is mycophenolate basically interferes with the synthesis of GTP, leading to impaired nucleic acid synthesis. And how it does that is it prevents the oxidation of inosine monophosphate to xanthine monophosphate intracellularly by inhibiting that step, which is the rate limiting step in this pathway. of purine synthesis, the inosine monophosphate dehydrogenase. Now, this enzyme is supposed to oxidize inosine monophosphate to xanthine monophosphate, which further forms guanosine monophosphate, and that leads to purine synthesis. And since T lymphocytes and B lymphocytes are heavily dependent on this mechanism, this pathway for synthesis of purines, unlike other cells which can use the salvage pathway, hence their proliferation and therefore activation sort of is interfered with when MMF acts. MMF also has a lesser known mechanism of effect, that is on the inducible nitric oxide synthase. By reducing its activity, what it does is it does not interfere with the constitutive nitric oxide, which is necessary for many pathways, but it affects the inducible nitric oxide synthase, which is important in activated macrophages and in mediating inflammation in various sites. So it has some other anti-inflammatory property as well, mycophenolate mofetil. So this is chiefly through reduced generation of NO and peroxynitrate, which are injurious to tissues. So the indications in nephrotic syndrome are fairly clear. Obviously, it has been very often used in the last 2 decades in steroid-sensitive nephrotic syndrome in reducing the frequency of relapses in patients with frequently relapsing and steroid-dependent nephrotic syndrome. This remains the most important usage for this drug, at least in these parts of the world where it is relatively recent in usage. Steroid-resistant nephrotic syndrome, we tend to use it for maintaining remission following therapy with calcineurin inhibitors, and we'll come to that later. It has rarely been attempted for use of induction of remission and as monotherapy or in combination with CNI in patients who have not responded to calcineurin inhibitors. In both steroid-sensitive and steroid-resistant disease, applications have been found for MMF in maintaining remission, which has initially been maintained with use of rituximab, but subsequently MMF has been added, and we'll come to that as well briefly. So overall studies in steroid dependence. There were 2 early studies. One of these was from Germany, published in 2004 by Gellerman et al. And the other, earlier than that, was published in the American Journal of Kidney Diseases from our center. This was probably the first prospective study on the use of mycophenolate mofetil in steroid-dependent nephrotic syndrome anywhere. And basically, it was based on a small collaboration between a center in California and us, wherein Professor Bagga et al. Had studied 18 patients with steroid-dependent nephrotic syndrome who were about median age of 8 years and had usually failed, this is 70%, by mistake it's written as 0%, had failed 2 or more therapies, and MMF was dosed at about 30 milligram per kilogram daily in 2 divided doses. The plots on the side show that the relapse frequency in 6 months, annual relapse frequency was 6 relapses a year, which fell to 2 relapses a year during therapy with MMF. And following stopping therapy with MMF, the relapse frequency increased again. Likewise was the effect on the prednisolone dosage. As you can make out, the cumulative prednisolone dosage in milligram per kilogram per day fell during therapy with MMF and rose again slightly once therapy was stopped. Later, Professor Afzal, who was at Aligarh, who was a fellow at time, also published a retrospective cohorts experience of 42 patients with steroid dependence, wherein a similar impression was gathered that there were significantly fewer relapses per year using MMF, and there was significantly reduced prednisolone requirement with the use of MMF. There have been many studies thereafter in steroid-dependent and frequently relapsing nephrotic syndrome. Some of these are summarized here, including the initial study at our center, Gellerman et al. From Germany, Hogg, Okada, Fujinaga from Japan, and Burdine. These studies are all prospective work, which looked at children for about 1 to 2 years follow-up and looked at the relapse frequency. You can look at the dose variability here. As you can make out, doses have been fairly high. It's been between 750 to 1200 milligram per meter square per day, particularly in studies from Europe and Japan. Patients have had very good impact in terms of looking at the number of patients who have relapsed. Look at this, only 16 to 36% of patients relapsed while on therapy with MMF, which is impressive given that they would have been steroid dependent nephrotic syndrome to begin with. Tendency to relapse frequently was really rare. So only 0 to 16% of patients had frequent relapses during therapy with MMF. And the prednisolone requirement definitely fell down considerably. Similar has been the experience subsequently in patients who were studied retrospectively at different centers or had a combination of, say, retrospective and prospective follow-up component in those studies. So this includes a study from Kolkata. Dr. Sushmita had studied 46 children who were dosed at 20 to 30 milligram per kilogram, followed up for 3 years or longer. And about half the patients had relapses, but only 1/3 had frequent relapses. And prednisolone dose could come down in more than 70% of patients. Likewise, in a study again from Kolkata, the institute, I think it's the NRS Medical College, they indicated that dosing with 1200 milligram per meter square led to significant improvement in rates of relapses, in tendency to relapse at all or frequently. So again, you can make out the dose variability here. People have dosed by milligram per kilogram. So milligram per kilogram dose has ranged from 20 to 35 milligram per kilogram, whereas the mg per meter square dosage has ranged from something like, again, 900 to 1200 milligram per meter square per day in 2 divided doses. Now, we conducted at our center a randomized control trial some time back, comparing the efficacy of therapy with mycophenolic MMF and levamisole. Now, you know that both drugs have been used commonly, levamisole actually for 4 decades and MMF only since 2003. In managing patients with frequent relapses or steroid-dependent nephrotic syndrome. But there were no direct comparisons between the two agents in the sense that if a patient with frequent relapses walks in, which drug do you think would perform better? So we imagined looking at the efficacy of the agent in studies from across the world as well as from our own center that MMF should perform better. So we planned a superiority study, assuming that MMF would behave better than levamisole and provide more steroid sparing. It would reduce the tendency to relapse frequently more, and would result in a lower rate of frequent relapses. So we did this in a superiority design and targeted 132 patients, looking at the outcome of number of relapses and a 25% reduction in that rate. So we randomized 149 children, 76 to receive MMF and 73 to receive levamisole. All patients could be followed to 12 months, except one who was lost to follow-up at 8 months in the levamisole limb. And we included all these patients in an intention to treat analysis. And the results of the study, which were published in the Kidney International last year, indicated that the baseline variables were entirely comparable. We had a preponderance of boys of age median 7 years. 1/3 of them was steroid dependent and had disease for 3 years or longer and had prednisolone requirement of 0.5 milligram per kilogram daily. The outcomes, to our surprise somewhat, were quite similar using MMF and levamisole. We found that the relapse rate per person year was actually low for both the limbs, that is 1 relapse or so a year in both limbs. The proportion with sustained remission was about 1/3 to slightly more. Tendency to relapse frequently was lowered significantly in both limbs. It was just about 15% kids had frequent relapses. And therefore, the rate of treatment failure, which comprised frequent relapses, significant steroid or drug side effects, was really low, or late resistance. And you can make out from the Kaplan-Meier plot shown that the time to relapse or to relapse frequently was similar for the two limbs, that is MMF in blue and levamisole in red, shown here. So we could not demonstrate the superiority of MMF to levamisole in our open label randomized control study. For this study, we had, however, used a slightly lower dose of MMF than has been seen in other prospective and retrospective studies. We were dosing them at 750 to 1000 milligram per meter square per day. And this was probably one of the shortcomings of the study, that we could not dose them to the level that was studied in other studies, such as the German studies, where they went up to 1200 milligram per meter square. The other obvious shortfall of this study was the absence of therapeutic drug monitoring, whose role has been outlined so nicely by Dr. Ratna just ahead of me. The study, however, remains the only study that is available for MMF versus levamisole in the Cochrane meta-analysis, and obviously there's no difference in the risk of relapse or the risk of frequent relapses between the two agents. This study was another randomized control comparison between MMF and cyclosporin done by Gellerman et al. In Germany, and they randomized 60 patients with frequently relapsing nephrotic syndrome in an open label but crossover study design, which meant that all 60 patients were randomized to receive in the first year one agent, and the second agent in the second year. So there was no washout period, but patients were switched from one drug to the other at the end of the first year. So if you look at the two Kaplan-Meier graphs shown, you can make out clearly that cyclosporin graph holding up higher, which means that the tendency to be in sustained remission was better during the therapy with cyclosporin than during therapy with MMF, both for year 1 and for year 2. But the gap was closing up slightly in the second year, which indicated that probably cyclosporin has a slight carryover effect in the sense that the patients who were previously treated with cyclosporin were doing slightly better. So overall, the MMF was remission rates with MMF were 64%, whereas remission rates with cyclosporin were 85%. This was non-significantly different. However, we'll come to therapeutic drug monitoring later, but it was demonstrated in this study that patients who achieved good MPA levels based on AUC did do better, and they did almost as well as did patients who were treated with cyclosporin. On the other hand, patients who did not achieve good MPA levels, since they did pharmacokinetics, they could measure that, they were the ones who did poorly as compared to cyclosporin. The other advantage that they demonstrated with use of MMF was that at the end of study, the estimated GFR at end of year 1 and at the end of year 2 was better in the MMF limb than in the cyclosporin limb. So overall, these are the comparative studies for MMF. We have 3 studies that have compared efficacy of MMF with cyclosporin. 2 of these are randomized controlled trials. That is the first 2. Gellerman et al. We have just spoken about. There was another small study by Dorenstein, again from Europe, which included just 24 children and was closed early on. Then there was another open label study on 60 patients. There was comparisons, not an RCT, by Wang et al., which compared tacrolimus to MMF and demonstrated that MMF was probably similar in terms of similar rate of relapse or frequent relapses and a cumulative prednisolone dose. And therein, obviously, we've talked about the MMF versus levabizole study. So the first 3 studies, which are randomized controlled trials, have been included in the Cochrane meta-analysis on this topic and indicate that tendency to relapse on MMF versus cyclosporin, including 82 children, is higher on MMF. So that means patients on MMF are slightly more likely to relapse than cyclosporin. But as you can make out by the 95% CI, this difference is not significant. This is probably because these are just 2 small studies, Dorenstein and Gellerman, that have been included in this analysis. So that completes the role of MMF, mycophenolate mofetil, in patients with steroid-dependent nephrotic syndrome. There are other studies, recent studies, that have demonstrated that a couple of studies have shown that patients who are younger might tend to do better on MMF than patients who are older. The reason for this difference is not clear, and this has not been examined retrospectively. In interest of time, I have not shown those studies. There was also a small subgroup analysis on one of our outcomes that in the study comparing MMF to levabizole that we did, that seemed to suggest the same, but we didn't have any power in our study to examine that more carefully. The second place where MMF has been used in nephrotic syndrome has been whether it can induce remission of steroid-resistant nephrotic syndrome. Now, as members of this audience are well aware, the drug of choice for inducing remission in steroid-resistant nephrotic syndrome is currently calcineurin inhibitors. Now, this is based on good data from multiple studies, both in children and in adults, that indicate that calcineurin inhibitors, chiefly cyclosporin that has been studied in the past, and more recently tacrolimus, induce complete or partial remission of proteinuria in 50 to 70% of cases when examined in randomized controlled trials. Now, obviously, calcineurin inhibitors have got lots of problems, such as the problems of nephrotoxicity, the need for close monitoring because of the high risk of adverse effects, including nephrotoxicity, which can be acute and chronic, the risk of hyperkalemia, and multiple other adverse effects, such as gum hypertrophy, hypertrichosis with cyclosporin, hyperglycemia with tacrolimus, risk of hypertension, neurotoxicity, etc. So this large study in the United States called the FSGS-CT, or the Clinical Trial of Focal Segmental Glomerular Sclerosis, enrolled children and young adults all over the continent in a study that included finally 138 patients. 66 of these were randomized to receive small pulses of dexamethasone and mycophenolate mofetil. So 66 patients were randomized to the MMF plus dexa arm, oral dexa, and 72 patients were randomized to receive cyclosporin. Now, they had a very complex study design and flow. They were to assess their primary outcome at 1 year, but they had multiple secondary outcome measures at 6 months, 1 year, and 1.5 years. They had a scoring system whereby they were assessing their primary outcomes. So this was something like complete remission, complete or partial remission. There were various ways of examining. So a score of 1 or 2 was good and 3 to 6 was not so good scores. The table shows those scores, but in a nutshell, the gist of the material was that patients achieved complete or partial remission in a very small proportion of patients in both limbs. And these rates were not different. So patients, and 1/3 of patients roughly entered remission with MMF and DEXA, with cyclosporin slightly higher, but the proportion was not significantly different. Now, the reason for poor performance, even for cyclosporin in this study, is not very clear. Perhaps it's because they chose to randomize only patients with focal segmental glomerular sclerosis, which probably is a more difficult histology and has probably a poorer outcome. We do not know what was the reason. In our studies, in most other studies, patients would be randomizing patients with both minimal change disease and FSGS. All in all, this is the only study that has compared these two agents, that has actually looked at MMF in inducing remission. This is the only study that has ever looked at this aspect. And it was shown that it was no different than cyclosporin in inducing a remission of nephrotic syndrome. What about using MMF later? And this has been a far more attractive option for use in patients with steroid-resistant nephrotic syndrome. We do know from this experience of the FSGS-CT and from other anecdotal evidence that MMF probably does not induce remission well. However, patients with steroid-resistant nephrotic syndrome who have entered in remission with calcineurin inhibitors, there is a need to move away from calcineurin inhibitors later. Now, there are various options to do that. So once a child is in remission of proteinuria after having received calcineurin inhibitors, after a period of while, we try to taper the therapy. Now, this period of time has traditionally been 2 to 3 years, which is the time which it takes for any nephrotoxicity to set in usually. And usually we would try to take off calcineurin inhibitors overall. Very often what happens is that the moment you try to withdraw calcineurin inhibitors, patients start to relapse. These may be steroid-sensitive relapses, which is more common, but they can also be steroid-resistant relapses. So there is a need very often in patients with steroid-resistant nephrotic syndrome to maintain remission by switching to another agent. Now, the choice of this agent is not very clear. Very often, mycophenolate mofetil has been used for this role. There are not many studies on this topic, on how well mycophenolate mofetil works in patients who are in CNI-induced remission of steroid-resistant nephrotic syndrome. These are a few studies that are summarized on this slide. Again, one study from Germany, including 23 patients, which is a retrospective cohort, which had used therapy with MMF for a plus CNI for a mean of 7 years. So basically, this 7 years is a composite of therapy with CNI followed by therapy with MMF. So they have found that patients still remained well in after having converted to MMF. They had few relapses. They stayed well. Their antihypertensive requirements went down when they moved from cyclosporin to MMF, and the estimated GFR actually improved when they were switched to MMF, indicating that the nephrotoxicity risk that CNIs carry, that was taken away, and therefore the GFR improved. Similar has been the experience from different centers, including France and the USA. So all in all, retrospective series, which include almost a total of 70 patients, one more series apart from what are shown on the slide, indicate that the patients who are switched from CNI to MMF continue to do well, continue to stay in remission if we have switched to MMF. And that prednisolone can be taken off, eGFR improves, and hypertension gets better, and the CNI side effects kind of are taken care of. So looking at that, it seemed an attractive model to study. That is, how does it work out if we were to induce remission with tacrolimus, which was now the standard of care for management of steroid-resistant nephrotic syndrome, and see if MMF can be offered early on, soon after remission has been induced with tacrolimus. So at our center in the late 2000s, we started this study, which was looking at this aspect. So we took patients with idiopathic steroid-resistant nephrotic syndrome. We administered tacrolimus, and the patients who entered into complete or partial remission of proteinuria by 6 months of therapy, we randomized at 6 months of therapy with tacrolimus to receive either MMF or continue therapy with tacrolimus. So this was kind of an early switch. This was not a late switch as has been practiced in retrospective case series. So we did a switch of therapy from tacrolimus to MMF at 6 months of therapy with tacrolimus, hoping to minimize the nephrotoxicity risk overall. So we did do this in a non-inferiority model because we knew that MMF may not work out as well. We were willing to accept a certain, tendency to relapse, a certain risk of treatment failure, which was kept at I think it was at 20%, 30%. We felt that maybe we were willing to accept some treatment failure if it offered us the benefit of, improving, if maintaining remission, if it offered the benefit of other loss of nephrotoxicity, etc. But it did not work out. The study had to be terminated prematurely because the DSMB decided, based on the interim analysis which had been pre-planned, that MMF was not performing well and that the study had to be closed. So we closed the study after having randomized and looked at outcomes of 60 children. And as you can see in the survival plot, you can see that the time to treatment failure was significantly shorter in patients with MMF than in patients with tacrolimus. Far more patients with MMF were having treatment failure than were tacrolimus. And this was similar for patients with initial or late resistance, similar for MCD or FSGS, similar for complete or partial remission, boys or girls, and whether they had relapsed in the first So again, I have already summarized this part. What about using MMF in patients who have not responded to CNI? So patients with steroid-resistant nephrotic syndrome, as I said, 60 to 70% are expected to respond to calcineurin inhibitors. The remainder are not. Now, we didn't have genetics in the past, but now it would be the norm to do genetics in such patients. But in the past, there was no such experience available. So there have been anecdotal series, maybe 4 or 5 series in total, including less than just handful of children in each of these series, in which they have shown that if you were to add on MMF to calcineurin inhibitors, up to one third of children might enter remission. Now, how long this remission can be sustained, whether it is just postponing it to a state of non-response occurring even on the same combination later, we do not know. Even in our and then look at combination of such therapies. As monotherapy, there is really not much literature. And as you can make out from the FSGS-CT trial, MMF did not really do the magic in inducing remission. Probably it's also related to the inability to achieve MPA levels, as has been just discussed in the context of hypoalbuminemia. Of course, combination therapy means that the risk of leukopenia and serious infections increases. So anyone who's attempting to do such therapies must be very cautious and must counsel the families very carefully about the risk of adverse events. The other usage of MMF, as we had just discussed, has been in the context of therapy with rituximab. Now, what happens is that we have begun to use this monoclonal antibody that achieves B cell depletion to achieve sustained remission of nephrotic syndrome in patients who are in remission. returns. And we do know that B cells will come back in a finite time interval, definitely between 6 to 12 months, they will return. And therefore, what next? So the Japanese in a survey have shown that using MMF or other agents such as cyclosporin, continuing on giving those therapies or restarting such therapy maybe a few months down the line after rituximab works out in the sense that if you were to give the therapy, then patients will not relapse. Now, that is also kind of intuitive, isn't it? Because obviously, if you're going on giving immunosuppression, the child is likely to do well. Obviously, giving combination immunosuppression carries some risks. It carries risks of leukopenia, serious infections. And all in all, what have you achieved if you have not taken the child off drugs, if you have given rituximab? That has been our concern. But even so, we try to examine it in the small retrospective comparisons that we have had from our center's published experience of 193 patients. We looked at whether or not adding MMF afterwards was useful in these patients. So when we look at the patients who were steroid-dependent nephrotic syndrome in a background of chiefly steroid-sensitive nephrotic syndrome, simple, plain and simple garden variety steroid-sensitive disease, which is bad steroid-dependent, whether or not you add MMF, it did not seem to matter at all. As you can make out, the time to relapse was just identical in patients who received MMF or did not receive MMF. On the other hand, if you had a context of prior steroid resistance, that is, you were a steroid-resistant nephrotic syndrome and you have entered remission with calcineurin inhibitors or with some other therapy, now you are behaving like steroid-sensitive nephrotic syndrome, and then you are given rituximab to maintain remission. Usually, if you were to not follow through with any drug, or you were to not repeat rituximab, for example, then the kids would tend to relapse rapidly. And you can see from the Kaplan-Meier that without any therapy, they almost 100% have relapsed by 12 months or so. On the other hand, if you were to give MMF to this group of patients, they probably do well. The Kaplan-Meier holds up and the time to relapse is slightly postponed. Now, these are like, this was a unicentric study. The Japanese seem to feel differently about it. Now, what Dr. Tallis group in UK did was, they did a multinational survey. So they did a multinational survey, and the lower part of this slide indicates the results of that survey. They looked at, they put together experience from 511 patients in an international cohort. We contributed 165 patients to that study, and they looked at what happens with number of doses of rituximab and with or without maintenance immunosuppression, such as with MMF or with CNI. So what they indicated was that patients who received a single dose and did not receive any follow-through immunosuppression, they were the ones who were definitely having a shorter time to relapse and a high relapse risk. On the other hand, if you were to give 2 doses of rituximab, or if you were to give 2 or more than 2 doses of rituximab, the time to relapse was prolonged, and with or without maintenance immunosuppression, there was not really any difference. So essentially, it seemed to suggest that if you're giving a single dose of rituximab, you might require maintenance immunosuppression such as MMF to follow through. And actually speaking, Japanese practice has been this, using a single dose of rituximab, and then they follow through with MMF or CNI. On the other hand, some other centers like ours would use 2 doses of rituximab and not use a follow-through medication. So the top panel indicates the same. The 2 studies indicated here are 2011 and 2013 experiences of follow-through with cyclosporin or MMF, and both therapies have worked. Cyclosporin was probably better, but again, we know that cyclosporin is probably a more potent agent than is MMF. What about adverse effects? We have discussed in the prior talk about the significant GI disturbances that this therapy is known to be associated with. And this slide kind of summarizes the adverse effects profile observed in nephrotic syndrome in various studies, that is the retrospective and the prospective studies that were uncontrolled in nature. So you can make out that abdominal pain and leukopenia and infections are the major side effects that have been observed. Overall, their frequency has been 25% or lower. And this is actually slightly lower. The abdominal symptoms, at least, are definitely lower than is observed in a setting of a transplantation. But probably it is also because, especially in centers like India, where cost becomes a constraint, very often patients are underdosed, or drug level monitoring, of course, is not being carried out. So maybe the symptoms are related to the drug levels as well, and therefore the proportion with adverse events is slightly lower. Similar has been the experience with randomized controlled trials, because except for the GELMN study, none of them had therapeutic drug monitoring integrated in them. And overall, the studies that are listed over here, they had the first 3 studies had compared MMF to cyclosporin, and obviously they indicate that hypertension was lower in MMF, hypertrichosis was lower than in cyclosporin LEM, leukopenia was similar, GFR was better with MMF, the reduction in GFR did not occur. Other studies like ours and Wang et al. Have similarly indicated GI side effects with MMF, infections being similar in risk, and similar risk with levamisole as compared to MMF, just similar risk of leukopenia or raised aminotransferases. So the lower panel indicates the Cochrane summary of the comparison of adverse effects between MMF and cyclosporin. And as you can make out from the relative risk lowering, you can see that hypertension, increased body hair, and gum hypertrophy were definitely lower with MMF than with cyclosporin. The reduction in GFR, there was a tendency, but it was not significant. And lymphopenia also, there was no significant difference. We were just discussing about therapeutic drug monitoring and its role in kids with nephrotic syndrome. I have summarized 3 of available, actually there are 7 studies now on AUC in context of MMF use in nephrotic syndrome. We did not do any AUC, and we had slightly higher relapse tendency. I mean, they had comparable relapse tendency as compared to levamisole. If you look at the GELMN study that I alluded to earlier, you can make out that in the MMF group, the relapses were less than 1 per year. But if you were to look at the MPA exposure in terms of the AUC, area under the curve, in the first 12 hours, if the AUC was below 50, the risk of relapse the relapse rate was 1.4 relapses a year. Whereas patients who had achieved adequate AUC, more than 50 microgram per hour per ml, the tendency to relapse was almost non-existent. Similar was the experience by Hackel et al. They used a cutoff threshold of 45. And they have indicated that there is a 5-fold difference in the in the relapse frequency between the 2 groups. The panel on the side indicates, just pictorial diagrams from GELMN et al. Again showing the same, that the tendency to relapse was much more in patients with inadequate AUC levels, and the Kaplan-Meier's indicating the time to first relapse were much different with low AUC. And obviously, we just discussed about hypoalbuminemia, meaning that MPA is not carried across in the bloodstream and there is higher clearance, and lipids also interfere in the blood with its metabolism, and therefore patients who are in a nephrotic state might not have meaningful MMF levels in their blood circulation. So probably MMF, while in remission, might probably be holding up better in the blood. But obviously, I mean, Dr. Ratna has shown some studies to that effect, and we look forward to the results of those studies. Moving on, in renal transplantation also, there has been a similar profile. I'm just digressing a bit just to indicate how neatly the AUC determines the risk of rejection and adverse effects. So as you can make out from the panel, what is shown here is the proportion with rejection, and the x-axis shows the target AUC levels. So if the target AUC levels was 61, the rejection risk was 11%. If the target AUC level was only 16, the risk of rejection was 31%. The patient withdrawal chances, however, because of poor tolerance of MMF, was proportionate to the AUC targeted. So if we were targeting 61 AUC, almost half the patients withdrew because of not being able to tolerate the dose that was required to achieve this AUC. On the other hand, with a lower AUC target, the tolerance was much better. However, there are other studies also that show that MMF lowering is not a good idea in such patients because the risk of rejection really increases for every week of time that MMF dose is below the full dose. So MMF TDM has definitely far more connotations and implications in patients who are post-transplant than in a nephrotic setting, wherein it's more about relapse risk. Adverse effects, we've talked about GI adverse effects. One thing that I just wanted to highlight, because we tend to use it increasingly in older children also who are, growing out to be adults, and they are at that age when they will be transitioned into adult care. We do need to be careful in their use with adolescent girls in case they are at risk of pregnancy if they are married or not. So like embryopathy risk is considerable. So definitely MMF should not be going on in someone who is planning a pregnancy. MMFS, I'll skip this slide because the metabolism and the pathway has just been discussed by Dr. Ratna. Thank you. And just a bit about how we've also discussed this bit, that MPA levels probably are achieved in the blood later with the extended enteric-coated preparations, the sodium preparations. They achieve later, but they probably hold up for a bit longer. And there are studies in transplant context. There are 2 large studies in adult transplant recipients trying to look at MMFS versus MMF, whether there's a real difference. Overall, however, as you can make out from the green and from the orange and blue plots below, that the risks of rejection, the risks of graft loss, and actually the serious adverse events as well as the gastrointestinal adverse events are fairly similar. There is a small tendency, which is statistically insignificant, with Myfortic, that is the MMFS preparation, to have fewer adverse effects. But otherwise, there is not any major difference, at least so far, very, very in a big major way. But these could be part of not studied enough number of patients. I'll skip that. So overall, we don't have controlled studies in nephrotic syndrome to address these questions that come to our mind. What is the comparative efficacy of MMF in patients who have been achieving MPA adequate levels based on AUC? So we need to compare MMF to cyclosporin, to compare it to levamisole, compare it to cyclophosphamide, and see whether MMF is a superior agent or a comparable agent despite maintaining AUC levels in the range that we desire it to be. There has been some suggestion that MMF might work better in young children. So is there a rationale to use this agent preferentially when you encounter a young child with steroid-dependent nephrotic syndrome? Is it really more effective in the young age than in the old age? The comparative studies of MMF and MMFS preparations are not there in childhood nephrotic syndrome. We need them. We discussed about CNI refractory disease, how we need to study whether or not MMF added on to CNI might be a good idea, or is rituximab a better idea in patients who have not responded to CNI. In the same way, patients who have responded to CNI now need to be switched away from CNI to another agent. Is MMF better or is rituximab better? These are some of the questions that come to my mind when I talk about role of MMF in nephrotic syndrome. I'll just close with a glimpse to the upcoming ISPN guidelines, which many of our colleagues on the panel, as well as some in the audience, have been involved in the drafting of. So this is where the role of MMF is in patients with frequently relapsing or steroid-dependent nephrotic syndrome. It is a very, very useful frontline agent for patients who have not done well on prednisolone on alternate days, or are relapsing and showing steroid toxicity, or have a high steroid threshold. We do know that we don't have therapeutic drug monitoring outside of CMC Vellore at any center across the country. So at this point of time, we cannot integrate TDM into our algorithm. So what we suggest, based on very few 3 studies in nephrotic syndrome, that probably going up on the dose might be achieving better drug levels, and therefore upping the dose, it can probably be as good as using, say, a stronger agent. So we have MMF on both sides of this algorithm, therefore, that if a smaller dose doesn't work, probably edge upwards. From 600, you can go up to a dose range. The dose range is from 600 to 1200 mg per meter square. So you might start low. If the disease is stable on that, you can stay there, and you edge upwards if the child is continuing to relapse. The IPTA 2020 guidelines in steroid-resistant nephrotic syndrome have come up with MMF in some roles, and we have discussed some of these. That patients who do not respond to cyclosporin alone or tacrolimus, you may add on MMF. Patients who are doing well on CNI or need to be switched, you can switch to MMF. If a patient who is continuing to relapse while on CNI, you may switch to MMF or add on MMF. They also mentioned in the guideline that patients who have lowish GFR with steroid-resistant nephrotic syndrome, you might consider using MMF there as well. In our guidelines of steroid-resistant nephrotic syndrome, the recommendation to use MMF is in the places that we just discussed, that once a patient has responded to CNI and you want to switch therapy, you might consider MMF as one such agent. Anecdotal response basis is the reason why we say that patients who have not responded and genetic cause has been ruled out, therein you may consider adding MMF after counseling about adverse events. With that, I'll close here, Rajiv. I hope I have not taken too much of your time. Sorry.
Thank you, Aditi. Dr. Indra Agarwal, if you have any statement.
No, I think Aditi has done a really exhaustive review and covered lots of, provided a lot of data on this. And I think the last word has not been said. Like she mentioned, there's a lot more that we still need to see. And with limited use of therapeutic drug monitoring, we obviously have to see where we can go. But I think regarding the dose, I think we can even go up to 1500 per meter square. There are studies which show that even 30 to 40 milligram per kg, or even up to 50 milligram per kg can be used. So maybe if we are really pushed, and if there are no side effects, probably we could still try pushing that up further by monitoring counts and other GI effects in these children.
So, thank you, Aditi. Thank you, ma'am. I mean, what can I say? It was an excellent talk by Aditi, and covering all the aspect, and as happens with a good talk, ending up with more questions than answers. And we have got almost 50 attendees. We started with 51. We have got 48. So, thank you, Aditi. I'll ask two questions, which was the top in my mind, and then we will, if we have time, we will take other questions also. Why do I say if we have time? Because I was told by our institute that they were not anticipating that it will go beyond 9:30, so we might be cut off unless and until Zoom decides to give us some extra time. So one is a straightforward question to both Dr. Ratna and Dr. Aditi and Dr. Indra Agarwal, that doing MMF level is not easy. When do you want, or when do you advise us to do an MMF level, and we will stick with nephrotic syndrome? Aditi.
Should I answer? Because I'm the one who uses it more than the others.
Okay.
So sometimes it is basically seen in those, children who are not responding to treatment, whom you have, you think you have given adequate doses of MMF, but still they're not showing a response. So then we are using it.
And do we have any, like you are doing it in your lab, but does any of the commercial labs do it? And the other question, part of this was that minimal, I understand, is that you have to take 2 blood sample. Am I right?
No, at least 6. We are giving at least 6 samples, isn't it, Ratna?
Dr. Ratna?
No, to do the 6 hours AUC, we take 10 blood samples. But as I said, 10 blood samples. For children, it's really traumatizing. So what we have developed, sometimes Dr. Indra Agarwal request do the analysis, and with the 90% agreement, we can just predict a whole AUC. That is the beauty of doing limited sample study. So we can do with a 5 point, we can do it, or 4 point also, 95% agreement or 96% agreement.
So minimum is at least 4 point, is it?
Yeah, if you want 100% AUC with this good correct AUC, you need to do 10 blood samples. But if patient is economically, it's not, because our tariff rate has come down with the limited sample strategy, and the patient doesn't have to sit in the lab. They don't have to give so many blood samples. So that time we, and as clinician, Dr. Indra Agarwal request, we do by 4 points or 5 points also.
And some of the younger children, the ones who are smaller.
Sometimes we have 2 years old children also.
So Aditi, how frequently are you doing in MMF, in AIMS level?
There are no labs in the country other than Vellore that does MMF levels. None of the private labs do it. So we
Sumanta
have
Sumanta just put up, maybe Nexus does it. Sumanta Raut.
Maybe they send it outside. Maybe they send it outside. We don't know. But the point is this, that as has been pointed out, there isn't enough experience to suggest that trough level or single level will be enough. So how many levels are you willing to do? There is some studies in nephrotic syndrome, what they say, maybe a couple of studies say that trough levels have a modest correlation with AUC, may substitute. And there is one study in, I think, Therapeutic Drug Monitoring Journal in 2019 by Benz et al., which indicates that an abbreviated protocol over 2 hours with fewer sampling points might do well enough to mimic a 6-hour full 10-point profile.
So can I conclude that like MMF monitoring at the moment is not not clinically advised, but it is something where we should keep our eyes and ears open. In future, we might get more evidence about it.
It's
More
not
concrete.
feasible. It's not feasible at the moment. It is desirable, definitely.
Okay.
In my opinion, is that it's not only that achieving the therapeutic range. Most of children are, as we say, our children comes from the low socioeconomic. They cannot afford that much price or cost for the only for MMF.
Okay.
Along with that, they have to do other by other medicines. So my thing is that by doing that monitoring, you can save in both ways.
You can bring down the dose required.
Yes.
So that might be also another important point to study, look into.
Yep.
And one more from my side is like any advantage of enteric coated over the non-enteric coated in side effect or efficacy. Again, Dr. Ratna can take it, or any of the other.
As Dr. Aditi in one of this her presentation slide, she showed there is no difference between entry coated and non-entry coated, except that few children who cannot uh, avoid that GI side effect or some side effect. That time only we prescribe that. But I don't think so.
But is there any evidence that in those children moving on to enteric coated will have made them better?
So we have a few cases, Ratna will remember because often she guides us on this. And we have a few cases who were very non-responsive. When we switched over to the enteric coated, they did respond. And we were able to demonstrate a rise in level also, NPAEC. So it's not enough number for us to say. I think one of Aditi's final slide did say that maybe we should compare the AUCs between these two and just see as a whole how different are they in the response.
So at the moment, again, we don't have a strong evidence, but there might be some anecdotal. Okay, and one more was there was a question about how long to continue MMF in a steroid dependent nephrotic syndrome, now in remission, like doing well off steroid. So Dr. Aditi, how long would you continue the MMF?
So we are aware that MMF has probably been used for more decades in transplant context than in nephrotic syndrome, and therein you know that MMF is used for several years altogether. But we worry about using drugs continuously for too long because we don't know what long-term adverse effects might creep up later in terms of silent viruses getting activated and whatnot. So we tend not to use for longer than 3 years or so, even MMF, similar to the time duration that we would stipulate for, say, CNI or for levamisole, because we don't know their effects. Now, what happens is that over a period of 3 years, the child might be outgrowing the tendency to relapse frequently also. And if the child is showing infrequent relapses or sustained remission, definitely it would be a good idea to take them off the agent and see how they are doing. What would you do, ma'am?
Yeah, sort of similar. Yeah, about 2 to 3 years. If they respond, if they remain in remission, we try to taper them off. By at least if they've been in remission for about 1 year at least, and if needed, sometimes we give it for 2 years also. It kind of varies, but at least what I try to do is at least 1 year they should be in remission, and then only try tapering. Some relapse, sometimes they get back on it.
So I think we have answered most of the questions that were on the chat box. Either Dr. Ratna has kindly typed in the answers, or we have answered most of it. Among the panelists, any questions, Dr. Parida, Jayati Di, Susmita Di? Then quickly, because again we might get cut off.
No, my only, it is not a question. Thanks to Professor Indra Agarwal. I'm seeing you after a long time. Hello.
Nice to see
And
you.
thanks Aditi once again for, very comprehensively dealing with the topics, and almost all questions are answered in your deliberation. And Dr. Ratna, it's really wonderful to have a, insight about a drug that we are using for a long time now. Knowing still, there's so many uncertain things in pharmacology and area under the curve that still needs to be explored. And I'm sure in few years time from CMC Vellore, which is the only center which is doing this, area under the curve and therapeutic drug monitoring, we will be possibly having a better guidance for us clinicians to go about it in future. Thanks a lot. Thank
Thank
you.
you. Thank you.
Okay.
Thank you, sir.